Hello everyone, good morning. I'm going to again continue with the stomach tumors. The three tumors which are left over for us are one is the gastric lymphoma, the other one is carcinoid, and the other one is a gastrointestinal stromal tumor. Before that, because this is my last class, I'll be completing the esophagus and the stomach by today. So I just want all of you to answer a few questions. Okay. Before that, so tell me, did anyone listen to the lockdown 4.0 yesterday? So what are the things which they are trying to say? Hello, can you hear me?
Yes, ma'am.
So tell me what are the things that they're following in the lockdown 4.0? You can be wrong, so you just open your mouth and talk to me. That's all.
Social distancing.
You won't hear me, but you won't hear Modi too? Yeah?
Social distancing.
What?
Social distancing, right?
Okay. So what else? So now you're the only doctors in your family, for suppose. So what do you tell your family members to protect them from getting COVID? They expect you now. Your relatives will be calling you and asking you how to may protect ourselves. So what do you tell them? Please be loud.
Hand wash.
Hand wash. Okay, very good. May I know the name? Who is the person answering?
Revant, ma'am.
Okay, good. Next. What are the things you follow? You came out, for example, you came to GBP, you're back by lockdown 5.0, okay? Maybe after some time, May 31st or something. You're just going back. Then what do?
Wear mask.
Wear mask, okay?
Sanitizers using.
Okay, then you come to college. You're coming to college for suppose, and then you're going to your hostel. What do you think you have to maintain?
What?
See, basically, I'm asking you these questions to lighten you up. Nothing like I'm not going to teach you anything about COVID right now, but just so that you'll just be alert about whatever we have discussed in the last few days. I'll come back to that. So basically, about COVID, you have to just wash your hands frequently, sanitize. Then whatever clothes you're wearing, you just have to leave them. You must call somebody from your house. Then, you have to ask them to put a bucket near you, and then you have to put all the clothes inside and have a shower, and then wear some other new clothes. And up to you. For example, you've met with a COVID person and your clothes have got stained, first suppose. So what are you going to do? You have to disinfect them. You can't let everybody of your family get the thing, right? So what do? What do? Your clothes have got infected, so what do? You have to use the bleaching powder, put a 5 ml of it in the bucket full of water, then you have to soak your clothes for 6 hours. See, these are the basic things you have to know as an individual, not as an MBBS student. Okay? Yes, everyone? I can't hear you. Can you hear me? Yes? So coming to, I'll just go on with the lecture because I'm not able to hear anybody of you speaking. I spoke about the esophagus. What are the chief complaints when the person comes with an esophageal abnormality? Yes, anyone? See, the purpose of taking class is for interaction, not just I just do blah, blah, blah and then go. What are the chief complaints of a person coming with an esophagus disease? Yes? Yes, everyone. Tell me what are the things that you can have. Yes. Come on. So I don't find anyone speaking. Anyways, I've been repeatedly saying this as a summary and repeated. If you just watch my videos, you can answer almost all the questions in your coming examinations. See, the lockdown is maybe a purpose that you can utilize by utilizing the videos. See, again and again, the recorded videos are put in the website. So you just have to see and make sure you're learning, right? The purpose has to be fulfilled. Anyways, I'll just tell again. The esophagus chief complaints are dysphagia, adenophagia, halitosis, global sensation, that is feeling like a mass, and bad breath, reflux, heartburn, and all these things are the presenting complaints of a person having an esophageal disease. So now coming to the congenital anomalies. What are the congenital anomalies in esophagus? Yes? There are tracheoesophageal fistula, that is, there is a fistula that is formed between the trachea and the esophagus, so they won't separate as such. Then what happens? The baby has difficulty in breathing, so it has to be surgically operated. It is usually associated with what? Atresia, that is thin non-canalized canal, okay? And there can be duplication of the esophagus and agenesis, which is very, very rare. So after that, what we spoke about the muscular disorders, that is the upper muscular disorders and the lower muscular disorders. How the upper muscular disorders are different from the lower muscular disorders? Yes. I spoke to you in the last class saying that I will be taking questions in this session, but still none of you have at least watched the videos and then learned. What is the difference between the upper esophagus and the lower esophagus? The upper esophagus has the striated muscle and it is different from the lower esophagus because it has smooth muscle. So there are upper esophageal muscular disorders and the lower esophageal muscular disorders. Okay, then we spoke about Zenker's diverticulum, that is the weakening in the cricopharyngeal area where there is an outpoaching of the esophagus, its submucosa and the mucosa, and because of that, the patient has global sensation because of this outpoaching. This is Zenker's diverticulum. What is Plummer-Vinson syndrome? Plummer-Vinson syndrome. It is associated with esophageal webs and iron deficiency and oral mucosal lesions. Okay. Then what can happen if there is a stricture? There is fibrosis because of chronic esophagitis. Then what happens? Whatever we are eating, it won't go freely inside. Then you have to put a gastrostomy tube. You can't send it, pass it through it. Okay. What are the constrictions you have to remember while you're dealing with esophagus? I told you about the constrictions, that is anatomical constrictions and physiological constrictions, that is upper esophageal sphincter and the lower esophageal sphincter. And the other one is at the bifurcation of the trachea. That is, those are the three anatomical constrictions, and the two physiological constrictions are the upper esophageal sphincter and the lower esophageal sphincter, right? So coming to esophagitis, esophagitis can be infectious esophagitis, which is mostly commonly seen associated with opportunistic infections in immunodeficiency syndromes. Then reflex esophagitis, that is the reflux of the acid and the food contents from the proximal part of the stomach into the distal esophagus. Then what happens because of that? There is inflammation and basal cell hyperplasia. Then what happens? And chronic reflux esophagitis may lead to Barrett's esophagus. What is Barrett's esophagus? Barrett's esophagus is one wherein the stratified squamous epithelium of the esophagus is replaced by the intestinal type of epithelium. So how do you demonstrate that? You demonstrate that by seeing goblet cells in the esophageal layer and the columnar metaplasia, right? So the other one we spoke about, the varices. Where do you find the varices? Esophageal varices commonly associated with what?
Portal veins.
What?
Portal veins.
Portal?
Veins.
Portal hypertension. So that should be your answer, okay? Basically, there is a liver abnormality because of fibrosis. What happens? There is backflow of the blood. Then, because of that, collaterals are formed, and because of that, what happens? There is variceal formation. Okay. What is the medical emergency about varices? What is the medical emergency about the varices? See, I've unmuted all so that you'll be sitting silent and then answering me. You will not speak anything else, right? Tell all your family members. Be calm.
Venodilations.
What?
Dilations of the veins.
I can't get you. Please repeat.
Vasodilation, ma'am.
Vasodilatation of what?
Portal veins.
Portal veins. Okay. No, I'm talking about what happens if there is varices. A person comes with varices. How do you know that?
Blood
Okay, there is
vomitings.
portal
Blood
hypertension.
vomitings.
Then you want, what happens is that there can be a medical emergency. So you have to be observing the patient. Why? Because the varices may rupture, right?
Yes, ma'am.
Yeah. So what are the other muscular disorders you can see? Apart from these which you are seeing in the picture, what happens if the part of the stomach is going inside or parallel or into the pleural cavity of the above the diaphragm? What is it called?
Pleuritis.
No, it is called as hiatus, right? A part of the stomach is going inside of the esophagus. What are the
Plus
types?
esophagitis.
3 types. What are the types? Sliding hernia, then paraesophageal hernia, and then pleuroperitoneal hernia. Remember these 3 things, okay? So, see, if you're starting with any part of GIT, just remember what are the chief complaints. Just imagine some patient coming to you and then saying about some complaints, okay? Then after that, what do is you need to know the congenital anomalies. Then if there are any other non-neoplastic disorders divided into neoplastic disorders, then you divide them into benign and tumors. Now coming to esophageal tumors. What are the esophageal tumors, you know? What are the cancers? What are the cancers of esophagus? A person is chronic smoker. What can you expect in the esophagus? See, basically, I told you there are only 2 main important esophageal cancers you need to know. There are many uncommon things, but you need to know major 2, that is squamous cell carcinoma and adenocarcinoma. The Barrett's esophagus is a result of reflux esophagitis, then intestinal metaplasia will happen, and from that intestinal metaplasia, what happens? There can be a dysplasia, then there can be a carcinoma. Okay, so that is the formation of adenocarcinoma because you're finding mucus type of glands which will produce and recapitulate the normal glandular structure and function. So that is called as adenocarcinoma. Now coming to squamous cell carcinoma, that is How do you know it is squamous cell carcinoma? Under the microscope. You will see normal squamous epithelial cells, then you will find the stratification. The function of the squamous epithelium is produce keratin, right? So what do you find? In a well-differentiated squamous cell carcinoma, you find keratin pearls. So that's how you identify these tumors. So this is all about the esophagus. Okay, you just have to remember the congenital lesions, that is tracheoesophageal fistula and atresia, duplication, all those things. Then what are the constrictions? What are the reflex esophagitis, Barrett's, and the syndromes? There is Borjev syndrome, Malraux syndrome, and Plummer-Vinson syndrome. Plummer-Vinson, iron deficiency. Malraux syndrome associated with alcohol, that is the tear in the distal esophagus and the proximal stomach. Borjev syndrome is rupture of the distal esophagus only. So just remember all these things and then you're done with esophagus. Now coming to the other one, we've spoke about the stomach, right? What are the parts of the stomach? Yes. What are the parts of the stomach? My picture shows you everything. You can just see the picture and answer. You can just see the picture and answer. Come on, guys. What are the parts of the stomach? There's no point I talk about tumors if you don't know about the parts of the stomach.
Fundus, body, pylorus.
Excellent. So these are the parts, 4 parts of the stomach. So there is, what are the cells you find? The mucin secreting foveolar epithelial cells in the short tubular glands in the cardiac mucosa, and in the body fundic mucosa you have the parietal oxyntic cells, which will secrete the HCl and intrinsic factor, chief or zymosin cells, which will secrete the pepsinogen, right? The pyloric mucosa having the mucus cells and the long tubular glands. The pyloric mucosa will secrete G cells, it's gastrin, which will form like an enterochromaffin-like cells, and then they kind of stimulate the parietal cells to produce acid, right? So we spoke about the stomach, and we spoke about next we spoke about the inflammation of the stomach, that is gastritis. What are the types? How do you classify gastritis? How do you classify gastritis? Yes, come on. Acute and chronic, right? Acute gastritis is again acute H. pylori or Helicobacter pylori gastritis, then acute non-infectious gastritis and acute. Come on, guys. This is not the way. I have repeated, this is the 3rd time I'm repeating in the class. Acute gastritis, it's 3 types, right? Acute H. pylori, acute infectious and acute non-infectious. About chronic gastritis, I told you there are 3 types. That is type A gastritis, that is A for autoimmune, B for Helicobacter pylori, C for mixed, right? C is AB actually, it's not C. So you're not even correcting me, right? It's type A, type B, and type AB, right? So type AB, where does the lesions occur? Which part? Type AB, which part of the stomach is involved? It's the antral in the body. Okay, according to the extent of inflammation and metaplasia and the activity of inflammation, again we divided into the gastritis into chronic active gastritis, chronic atrophic gastritis, gastric atrophy, chronic hypertrophic gastritis, and others, right? Chronic hypertrophic gastritis is otherwise called as chronic hypertrophic gastritis is otherwise called as Menetrier's disease. So we spoke about these 5 types of gastritis, right? And we also spoke that there is something called as Helicobacter pylori gastritis, right? What is the specialty about this Helicobacter pylori gastritis? In acute gastritis, what do you find histologically? You find neutrophils, acute neutrophils. And when there is edema, then there can be hemorrhage. In chronic gastritis, what do you think are the cells? There can be lymphocytes, macrophages, and plasma cells, right? So in chronic Helicobacter pylori gastritis, what do you find? In chronic Helicobacter pylori gastritis, you find the neutrophils and also the subepithelial plasma cells, and they also form pit abscesses. And the Helicobacter pylori can be associated with formation of hyperplastic polyps. It can be associated with atrophic gastritis. Then it may cause proliferation of B lymphocytes, and it may be causing 50 to 60% of the mucosa associated lymphoid tissue or the MART, right? So then I also spoke about the formation of gastric cancer, right? So this is about the gastric carcinoma with Helicobacter pylori. What do you think the patient presents with when you have a stomach cancer? So somebody says, somebody in your relative's family, they come and tell you that we have some problem regarding the stomach. What do you think will be the chief complaint of them? What are the chief complaints? Come on guys, you never experienced any kind of a stomach pain or what?
Pain in stomach.
What?
Stomach pain, ma'am.
Okay, how do you explain that? See, stomach pain is something what the patient tells you, not what a doctor, it's not a terminology, right? You said pain, okay, fine. Then what can happen? What else can happen?
Enlargement.
Come on, yeah. I mean, it's like gastritis. How do you feel? It's a heartburn, epigastric pain. Then there can be vomiting. There can be hematemesis. There can be diarrhea associated with rapid gastric emptying, right? So these are the things you can experience when you have a chief complaint of stomach. Now coming to congenital lesion, what congenital lesion I spoke about while talking about the stomach? Congenital pyloric stenosis, right? What happens when the pylorus is obstructed? What do you think will happen? The food which is getting digested here won't pass into the small intestine, right? So what happens? There will be a mass. So the mass can be visualized in an infant. So what happens? There will be projectile vomiting. The infant can't be alive if you are not treating it surgically. So this is about the congenital pyloric stenosis. Is there a possibility of an acquired pyloric stenosis? Yes, if there is a carcinoma here, there can be pyloric canal obstruction, and that the food which is getting digested here won't go into the duodenum, and that's how you can have an acquired pyloric stenosis, right? So we spoke about, see, again I'm telling you, whenever you're reading something, read what will be the chief complaint if a patient comes to you, then what are the congenital lesions, then the inflammatory lesions like gastritis, then the non-neoplastic lesions, right? So just make the thing easier for you, okay? So coming to the non-neoplastic lesions, I told about hypertrophic gastropathies in the last class. What are the chronic hypertrophic gastropathies? What are gastropathies? That means the inflammation is minimal and there is a gastropathy or pathology associated. So menetrier disease, I also told you, is chronic hypertrophic gastritis. The age group is 30 to 60 years. Body and fundus is the most common location, and the predominant cell is a mucus cell. So here, the association with adenocarcinoma is present. Okay, remember this about the menetrier disease. Now coming to Zollinger-Ellison syndrome. See, I just told you while talking about the Zollinger-Ellison syndrome, a person can come with gastritis or a peptic ulcer disease to you with some degeneration. You put a scope, then you find degeneration or necrosis of the gastric mucosa, and because of that, there is no proper digestion happening. So when you examine or think about Zollinger-Ellison syndrome, a patient, any patient today eating outside food or spicy food can come with a complaint of gastritis. You and me, everyone. So when do you think in terms of Zollinger-Ellison syndrome while examining that patient? Yes? What is this?
Man.
Men. What is men? Multiple endocrine neoplasia. Type 1 is associated with parathyroid adenoma and pituitary adenoma and also gastrinomas. Gastrinoma is nothing but Zollinger-Ellison syndrome. So when I already am examining a patient with a known case of multiple endocrine neoplasia, then you need to look for any part of men. For example, I know that the patient is having a parathyroid adenoma, then I look for Zollinger-Ellison syndrome also. Okay, the age group is 50 years and the most common location is fundus. And the parietal cells are more common, highly hyperplastic than the mucus and the endocrine cells. The inflammatory cells are the neutrophils, and there is absolutely very less association with adenocarcinoma here. See, when a person is having multiple gastrinomas, okay, the G cells, what they do, they kind of stimulate the parietal cells to produce more acid. There is more regurgitation happening, more gastritis happening. Then multiple peptic ulcers, if they are present, and the patient is complaining of diarrhea, you eat and then you want to just rush to the loo, then you will think of Zollinger-Ellison syndrome in accordance to men also, right? Just remember these two here. And then coming to inflammatory and hyperplastic polyps. So what is a polyp, guys? Polyp? A polyp is a finger-like projection that projects into the lumen, right? So it can cause obstruction, anything. It is usually be associated with infectious condition, inflammatory condition, or a neoplastic condition. It can represent anything. So the age group associated with the inflammatory and hyperplastic are 50 to 60 years. Usually antrum is more commonly associated location than the body. The mucous cells are involved. See, I told you the inflammatory and hyperplastic lesions are usually associated with chronic gastritis and H. pylori, and there can be occasional transformation into adenocarcinoma, right? H. pylori can cause adenocarcinoma as well as lymphoma, right? There is something called as gastritis cystica, and in the age group is variable, location is body, there is a mucous cyst lining here. And then risk factors are the trauma or the prior surgery, which may cause the dilatation and mucous cyst lining will be there. But this is about gastritis cystica. And then fundic gland polyp. Fundic gland polyp, like that of the hyperplastic polyps, it can be associated with familial adenomatous polyposis. The gastric adenoma is also associated with familial adenomatous polyposis. So usually hyperplastic polyps are not associated. Initially, the surgeon may think that you are looking at a hyperplastic polyp, then it may suddenly transform into something else. Then you must think about the syndromic association and all, right? Usually the hyperplastic or inflammatory polyps are most common polyps and they are not neoplastic polyps, okay? Whereas the fundic gland polyp may be associated with familial adenomatous polyposis like that of a gastric adenoma, right? So here in the fundic gland polyp, the predominant cell type is parietal and chief cells. The fundic gland polyp will be seen in patients who routinely take the proton pump inhibitors like omeprazole, rabeprazole, all those things. So there's no association with adenocarcinoma. Coming to gastric adenoma. Gastric adenoma, by the name, like, you know, it is the proliferation or a benign tumor with glandular cells. So most commonly associated with antrum more than the body. It is also associated with chronic gastritis, intestinal metaplasia, and FAB, that is familial adenomatous polyposis. This is a syndrome wherein there are multiple polyps in the gastrointestinal tract. That can be stomach, that can be colon, that can be small intestine, right? So what happens is that there is association with adenocarcinoma, very, very frequent, and we can have a family getting affected because of the familial adenomatous polyposis syndrome, right? So when we have to look for anything when you're examining a polyp, for example, you put a endoscope in the patients, and then you're finding a polyp size of 1.5 centimeters or 2 centimeters. Then what do? Do you think you have to resect it then and there? I told you the size is very important while you are examining a polyp. Okay, you have to make sure that you are trying to do a histopathological examination when the size is more than 1.5 centimeters, because dysplasia can be present in polyps more than 1.5 to 2 centimeters. So remember, the size is crucial here. Now coming to gastric carcinoma. Again, what are the chief complaints when a patient comes with gastric carcinoma? Same that of those of chronic gastritis, right? There can be weight loss, there can be cachexia, okay, in addition to all these things, and there can be enlarged lymph nodes sometimes that can be giving you a clue to look for gastric carcinoma in addition to the features of the chronic gastritis. So it can be classified into a conventional classification, that is an early gastric carcinoma. Early means it's not the time, but it is about the infiltration of the tumor into the mucosa and the submucosa only. It won't go deeper. So obviously there is, in the early gastric carcinoma, the prognosis is good, and usually we see a well differentiated carcinoma. Then coming to advanced gastric carcinoma, there are other types. We will be speaking in detail about them. Then classification based on depth of infiltration. I told you expanding carcinoma and infiltrating carcinoma. Expanding carcinoma is that they occur in groups, they have a margin. And infiltrating carcinoma, they occur singly. I told you it's like zombies. If you watch the movie World War Z, then you know they go just singly, and then they kind of infiltrate more. So this is advanced gastric carcinoma. Here you can see the ulcerative type, which is the most common pattern. It can be flat or infiltrating with necrotic base. The carcinomas are poorly differentiated adenocarcinomas. Fungating carcinoma is the second most common pattern, like caulifungating, the cauliflower-like growth projecting into the lumen. And it is usually papillary and well-differentiated adenocarcinoma. Scirrhus is like leather, right? Linitis plastica, common in pyloric antrum. Usually diffusely enlarged wall is seen whenever you're finding a scirrhus carcinoma. Usually it's signet ring carcinoma and adenocarcinoma. The colloid carcinoma most commonly seen in fundus. You find abundant pools of mucin. Like you just jump into a pool, for example, there are 4 or 5 in the swimming pool. So the cells will be, the neoplastic cells will be floating in that pool of the mucin. Okay, they are usually the signet ring cells. The ulcer cancer, the malignant lesions, they are adenocarcinomas without any specific features. So obviously, the early gastric carcinoma, while the depth is just about the submucosa, if it is infiltrating more, it can be advanced gastric carcinoma, and then you can find a lot of variations in the advanced gastric carcinoma and its prognosis. Usually, the advanced gastric carcinoma is the stage where you find the patient having diagnosed with cancer. So the symptoms, the paraneoplastic syndromes, I told you. What are paraneoplastic syndromes? The cancer itself is not causing any kind of the thing, but something produced by the tumor cells will have an effect or will produce a disease that will be known as a paraneoplastic syndrome, right? Lesser-Trillard syndrome, wherein there is seborrheic keratosis because of proliferation of keratinocytes. You find multiple spots on the skin. Then polyarthritis nodosa because of increased necrosis of the medium-sized arteries, kidneys, and heart can get affected, and because of that, there can be kidney failure or myocardial infarction. Troisier syndrome, that is elaboration of tissue factor by the tumor cells, will cause thrombosis that can be migratory. Then acanthosis nigricans, it is just darkening of the mucosal folds, that is the armpits and all skin folds. Then coming to the Troisier sign, that is the lymph nodes can be enlarged in the left supraclavicular region, and it is called as a Bichos node. The node is called a Bichos and the sign is Troisier sign. There can be dysphagia or difficulty swallowing when there is pseudoachalasia, like seeing a picture when the tumor is situated in the upper part at the cardiac region and obstructing the food. Right? So there is something called a Sister Mary Joseph sign, that is enlarged belly button lymph nodes. So the complications I told you, Lesser-Trillard, polyarthritis nodosa, and pseudoachalasia-like syndromes. All these things can occur. Right? What are the complications? There can be peritoneal metastasis into the peritoneum that the cancer cells may go. And then there can be lymph nodal metastasis around the umbilicus and the belly button may show the Sister Mary Joseph node. And then there can be supraclavicular node, that's a Bichos node. What is the sign, guys? What is the sign? If you are watching the left supraclavicular lymph nodal enlargement, what's the sign called? It's a Troisier sign, okay? And to the distant organs like liver and the ovaries. In the ovaries, the ovarian stroma is being replaced by the carcinomatous cells, that is called as Krukenberg's tumor, okay? I'm just repeating all these things so that you get acquainted to all this terminology, and then it will be easy for you. Now coming to the original topic, that's the lymphomas. The age instance is 30 to 40 years. There are two types, that is diffusely infiltrating and polypoid type. Microscopically also, there can be martoma or a high-grade large cell immunoblastic lymphoma. Usually, there can be 3 translocations associated with these type of lymphomas. That is translocation 11-18, translocation 1-14, translocation 14-18. Just remember these things, okay? So the age is not very advanced, it's just a middle age. Right? So how it happens? Usually the Helicobacter pylori can cause chronic gastritis. I told you what happens. Chronic gastritis, you have to remember there can be lymphocytes, neutrophils, subepithelial plasma cells, then pit abscesses formation, then it can be associated with hyperplastic polyps, and because of that chronic gastritis, there can be proliferation of these B lymphocytes, and then the polyclonal B lymphocyte proliferation can turn into monoclonal lymphomatous or neoplastic cells. Okay, how can a person get eradicated of this? See, there is a normal lymphoid tissue in the gut to protect from whatever food we eat. There can be some bacteria or something which can be infecting that food. So that's the reason why whenever we are taking the food, we have to have something which will protect us. So, if you are the king of your body, there can be some warriors in your stomach which will help the enemy from just getting out. So the enemy can be a bacteria or anything like that. So because of those warriors for you are these B lymphocytes which are present normally in the gut. They are called as mucosa associated lymphoid tissue that are normally present. So whenever there is a bacteria like H. pylori, there can be chronic gastritis, and proliferation of B lymphocytes can happen. And initially they are reactive, but then over the years they can transform into a neoplastic process, then they can form a lymphoma, right? So to establish the lymphoma coming from Helicobacter pylori, if we are treating a Helicobacter pylori infection, the recurrence rate of the lymphoma after treatment is very low. So that's how I can establish that this lymphoma has come from Helicobacter pylori. Okay. So here you can see the columnar mucosa, and then here you can see the neoplastic lymphocytes replacing the normal mucosa and the submucosa, and here you are seeing the neoplastic lymphocytes. And here this is small intestine. Actually you can see the serous nodules here. So usually there is mucosa, submucosa, muscularis, and then the serosa, right? What different it is from the esophagus? The esophagus does not have serosa, it has just adventitia. So here in the small intestine, just like the stomach, it can have the serosal nodules, which can be demonstrated. So you have to see, whenever you are examining a patient for cancer, you have to know whether it has gone to lymph node, whether it has gone to the serosa, because the layers, the depth of invasion is important, and the nearby organ invasion is important, the lymph node, the hematogenous spread, everything is important for staging of the cancer and the prognosis of the patient and the disease. So here you can see the diffuse thickening here. Okay, this is how a lymphoma presents. Okay, so what are the presenting symptoms? There can be dyspepsia, epigastric pain, hematemesis, melena, constitutional symptoms such as weight loss can also be present. So usually whenever we are seeing something in the gastric tumor also, it presents similar to that of the chronic gastritis in addition to something like weight loss. See, how do you know, how do you examine the patient with the, if you're an oncologist, you become an oncologist. Now a patient comes with a stomach cancer. So what do you kind of, before you do an invasive test, what scan you ask them for to know about the metastasis? Yes, guys, what scan do you ask them for? See, there is a person you know is coming with stomach cancer to you. You know the patient is having stomach cancer. You just want to know about the spread. What scan you will ask them? PET scan, guys. This is something like everybody should know. I mean, it's PET scan. You will examine the whole body for the metastasis, then the staging gets easier. And wherever you want to know if they are just reactive lymph nodes or lymph nodes infiltrated by the tumor cells, you will just pluck out the lymph node and send it to the histopathological examination so that the staging becomes easy. Now coming to the other tumor, that is gastrointestinal tumor, the most common mesenchymal tumor of the abdomen. So carcinoma, epithelial tumor, lymphoma we spoke about is neoplastic proliferation of B lymphocytes, which can initially be a martoma, then it can go into high-grade lymphoma. Then now we are speaking about a stromal tumor. Okay, we have the muscle layers. Okay, so the muscle layers can get affected. So because of that, there is something called as gastrointestinal tumor, stromal tumor. What is it? It is having a common stem cells with the interstitial cells of Kajal. These are the pacemaker cells for gut peristalsis. So I eat something, I want something to get down. There should be a nerve muscle coordination for the food that should be propelled down into the stomach. So because of that, these are the important cells. Okay. Like just Kajal cells express c-KIT, also known as CD117 and CD34. See, CD is cluster designation. That's a number given to those kind of cells. Okay, so cluster designation 117 or CD117 and CD34 is expressed by these Kajal cells. Okay, and there is usually the incidence is at 60 years associated with carney triad. There can be a syndrome called as gastric cyst, paraganglioma, and pulmonary chondroma. All right, so this is just a syndrome you need to remember. Okay, and just can also be associated with something called as neurofibromatosis type 1. So the mutations can occur in c-KIT, that is CD117, and platelet-derived growth factor receptor alpha, that is PDGFR-A genes. So we are just talking about a mesenchymal tumor. The cells that is having a common stem cell, that is the interstitial cells of Kajal. They are having cluster designation 117 and CD34. And then they are associated with carnostride, neurofibrinosis 1. And the genetic association can be with mutation c-KIT and PDGFR-A genes, right? Morphology, they are up to 30 centimeters. See, polyp, you're speaking about 1.5 centimeters. Oh my God, and you just pluck it and examine it. So see how large these tumors are. They can be up to 30 centimeters, solitary, well circumscribed, fleshy mass. You know, it's just very fleshy. The spindle cells, you're talking about stroma, they are spindle, right? Tumor may metastasize to liver and present as a nodule on the serosal surface on the peritoneum. So there can be metastasis occur like any other tumor. So what are the types? Spindle cell type, epithelioid type, and mixed type. 3 types of GIST are present, that is spindle, epithelioid, and mixed. So immunohistochemistry, what does immunohistochemistry do? It will give a clue on the origin of the cell of the tumor. For example, you're having a tumor on your hand, you just cut it, then you're examining it under the microscope, you get a diagnosis, but you want to know what is the origin of the cell, whether it is the blood cell, whether it's smooth muscle cell, whether it is a breast cell, whether it is prostate cell, what type of cell it is. So for examining that, we do an IHC in the gastrointestinal stromal tumor, then we find the c-KIT, that is CD117 in 95% of the cases of the gastric GIST. Remember that. Then the prognosis correlates with tumor size. I told you it can go up to 30 centimeters. Mitotic index, my number of mitotic figures per hyperfield, and the location. The gastric GIST being somewhat less aggressive than the small intestine. And recurrence or metastasis is rare for gastric GIST under 5 centimeters. So that's the reason why we are talking about the size of the tumor being very crucial in the prognosis of the GIST tumors. Right, so this is the size of the tumor you're seeing here, very large, right? And how it is, you can just see, it's a large tumor, okay? And here you can see under the microscope, these are the spindle cells, which you have bizarrely arranged here. And then you can see this IHC or immunohistochemistry positive for CD117, okay? Now coming to the other tumor, we've seen gastric carcinoma, lymphoma, GIST, and now carcinoid tumor. Carcinoid tumor, I told you, is associated with the endocrine system. It is well differentiated neuroendocrine cancer, right? So this is the lungs can get involved, the tracheobronchial tree can get involved, the small intestine, the esophagus, the large intestine, anything can get involved in the carcinoid tumor. Okay, so the gastric carcinoid may be associated with atrophic gastritis and Zollinger-Ellison syndrome. I told you Zollinger-Ellison syndrome is gastrinoma that very frequently can be associated with a carcinoma only if it is a carcinoid, right? So the carcinoid is the term applied for carcinoma like, and then you can see these carcinoid, see any cancer, any skin cancer, or a stomach cancer or any type of cancer, if it is well differentiated, will try to recapitulate its structure and its own function. For example, you're seeing a squamous cell. The squamous cell will produce keratin, so that the function will be retained even in the cancer cell. Okay, you do not want the keratin there and still the keratin is formed. And then in adenocarcinoma, you do not want the mucus pools or all of that, but you know, the glands which are present there are secreting more mucus and then causing more destruction. So a well-differentiated cancer is the one which is trying to recapitulate or express its own function. So here as a carcinoid, you can see that the neuroendocrine cell will try to produce the endocrine substances so that you can get a clue that you are looking at carcinoid, which is different from a carcinoma or a mesenchymal tumor or a lymphoma, because hormones or the endocrines which are released or the vasoactive substance, they have a particular function to do. Okay, here the neuroendocrine cell, for example, what kind of vasoactive amines it can produce is that the 5-hydroxytryptophan and other bioactive substances can be formed from a neuroendocrine tumor cell, and these get metabolized into the liver. How? By monoamino oxidase and aldehyde dehydrogenase, and they form the substance which can be excreted in the urine. And if this does not happen, that means if the liver function is getting affected and these vasoactive amines are just retained in the body, what happens? They go to the heart and then they cause the symptoms called as flushing, diarrhea, dyspnea, palpitation, and bronchospasm. So the complications are the carcinoid, heart, mesenteric fibrosis, pellagra, and neuropsychological disorders and carcinoid crisis. So if there is a metastasis to the liver by the carcinoid tumor, if there is a metastasis from anywhere in the gut to the liver will lose its function of metabolizing this vasoactive amines, and they retain and cause this syndrome called as carcinoid syndrome, right? So these are the various regions where the carcinoid tumors can be seen. Esophagus, very rare. Stomach, less than 10%, and it can release histamine, somatostatin, and serotonin. And then proximal duodenum, usually the gastrin, somatostatin, and cholecystokinin. Then you can see that it is associated with Menon-Zollinger-Ellison syndrome. The jejunum and ileum, you see here, serotonin, substance B can be there. And you can see that small intestine carcinoids are very, the fraction is very high and they're present throughout. And then the substances which will be released will be associated with the metastatic disease, and they are aggressive, forming a carcinoid syndrome, right? So appendix, colorectum, all this can be. Here you can see yellowish submucosal button-like substance here. That is the carcinoid gross appearance. The overlying skin can be intact or can be torn. Here you can see the mucosa and then the carcinoid. They can be arranged in form of islands, trabeculae, strands, okay, and nests. And you can see this small blue round cells associated with the stipple chromatin, that is the feature of the neuroendocrine cell. And then in electron microscopy, you'll find the neurosecretory granules. That is the key feature of the thing, right? So here you can see the location, the foregut carcinoids. Foregut carcinoids is proximal to ligament of Freitas, that is with esophagus or the stomach, right? And midgut carcinoids, I told you, midgut, the small intestine, very aggressive. There can be local invasion, the presence of necrosis, mitosis, the depth and the size will have the effect. Hindgut carcinoids discovered just incidentally. Okay, these tumors are more than 2 centimeters and almost uniformly benign. The rectal carcinoid produce polypeptide hormones when symptomatic, present with abdominal pain and weight loss. Okay, so we spoke about the gastric carcinoma, lymphoma, carcinoid, GIST, right? We spoke about these tumors. Now, to summarize all of this early gastric carcinoma, I told you just the mucosa and submucosa gets involved. The advanced gastric carcinoma has several morphological types, ulcerative most common, fungating, the cauliflower-like growth, scirrhous, the leather bottle type, the colloid, pools of mucin, ulcer cancer with no specific features. Then signature type and colloid, I told you the mucinous variants. The GIST, I told you stromal tumor with spindle cell positive for c-KIT, that is CD117. Right, gastric carcinoma may spread into the adjacent structures by hematogenous and lymphatic routes. Quiz, I think I'll take next time. Thank you so much for listening with patience. Mm.